A molar pregnancy, what you need to know about it. Molar pregnancy, often referred to as gestational trophoblastic disease or hydatidiform mole, is a rare pregnancy complication that develops when there is a gross abnormality of the trophoblast, the cell that aids in the embryo's attachment to the uterine wall and contributes to the placenta. Rarely does it happen inside the fallopian tube, although it can happen in the uterine cavity. A complete hydatidiform mole and a partial hydatidiform mole are the two types of molar pregnancy. Causes: when the father's 46 chromosomes fertilize an empty egg, a complete hydatidiform mole results, and because the mother's chromosome is lost, only the father's chromosomes are duplicated. There are 3 sets of chromosomes in partial hydatidiform moles, 46 chromosomes from the father and 23 from the mother. Instead of 46, the embryo now has 69 chromosomes. Features of the complete hydatidiform mole. Here, the embryo dies even before the placental circulation forms, therefore neither the embryonic cord nor membrane are visible. The cytotrophoblast and syncytiotrophoblast undergo proliferative alterations, resulting in the formation of clear hydrophobic vesicles that appear in loosely hanging clusters resembling a bunch of grapes. These vesicles can range in size from being quite large and visible to being very small and invisible. These vesicles inside the uterus can get so big that it might even be mistaken for pregnancy. Partial hydatidiform mole features. Evidence of an embryo, fetus, or membrane is present. This is due to the fact that the fetus dies during weeks 8 and 9 of pregnancy. The syncytiotrophoblastic layer is the only place where proliferation occurs, and it does not spread over like in a complete hydatidiform mole. Risk factors. Women under the age of 20 and those over the age of 40 have a higher risk of developing a molar pregnancy. Additionally, if there has previously been a molar pregnancy. Signs of molar pregnancy. Absence of menstrual flow, also known as amenorrhea. Increased pregnancy symptoms beginning at 6 to 8 weeks in a complete molar pregnancy. Hemorrhage or a discharge that is stained with blood. Excessive nausea and vomiting caused as a result of elevated levels of human chorionic gonadotropin. Diagnosis. The signs and symptoms given above are used to make a diagnosis. Confirmatory diagnosis is made with the passing of a vesicle from the vagina. The properties and appearance of the grape-like structure are revealed via an ultrasound examination. Even after 12 weeks, elevated serum hCG levels are conclusive. The high surface area of the vesicles is what causes this rise. It's important to rule out uterine tumors, threatening abortion, twin pregnancies, and hyperemesis gravidarum. Management. In some cases mole detaches and it is expelled completely, but where the above is not the case. Vacuum aspiration or dilation and curettage are done to remove all trophoblastic tissues to avoid reoccurrence. A follow-up. Sometimes, a mole can develop into an invasive mole that can develop into a chorion carcinoma and become malignant. The following actions are taken in the follow-up. hCG is immunoassayed in urine. Dilatation and curettage are performed if there is still a high level of suspicion of choriocarcinoma, and the cuttings are then sent for histology. For 2 years, pregnancy should be avoided. No hormonal contraceptives until the hCG level returns to normal. Complications. Common complications include hemorrhage, choriocarcinoma, recurrence, infection, preeclampsia, and anesthetic risks.